dysregulation of insulin. So there's insulin resistance that comes about. And also because you have a big wound, your body is trying to cover up for that wound and try to increase the rate of healing. So you find that the demand for nutrition increases in that particular patient. It's not the same. At the same time, you need to control their sugars. I won't talk about this again, so make sure that you understand that concept. There's dysregulation of sugar. So you need, in Barnes patient, you might have to give them metformin, you might need to give them insulin based on the RDS. So you find that some of them tend to have that issue. So let's talk about the zones. So you have the zone of coagulation, the zone of stasis next to it, and then you have the zone of hyperemia. Okay. So let me just, I think it's there, but Patrick Ochiem, do you mind telling us, explaining what either one of these is, starting with the zone of coagulation? Patrick Ochiem?
Can I just read?
No. I have to see whether you understood.
Okay.
Sent this before.
It's the area, immediate area of contact.
Mm-hmm.
Yeah, and so the surrounding tissue denatures.
Mm-hmm.
Yeah, and also there's loss of there's no blood circulation.
Okay, sir. So you just read the slide. In the zone of coagulation over here, it's not the surrounding tissue, so this was even an error. The cells at the direct point of contact are denatured and they burn, they basically are killed off. So that point is death. Okay. So there's no blood supply in that particular area. In the zone of stasis, it's like an intermediate zone, the purgatory of the burn. And at this particular point, the blood perfusion is very low or negligible, or it's just playing about. So if you don't give your fluids at this particular point, then that particular area becomes ischemic and then now becomes hypoperfused, and then edema and infection can happen in that particular area. Okay, so that place can now the zone of stasis can either go towards hyperemia or it can go towards coagulation. So if you don't give fluids, it worsens the situation. If you give fluids, then you ameliorate it. For what do you call this? If there's further damage, it causes hypoperfusion, edema, and infections. Okay. So the zone for hyperemia, this zone has increased blood supply. So this is the outermost zone. This is zone farthest from the point of contact. And most of the time, this place will recover. So not unless something bad really happens, like sepsis or reduced blood pressure, you will not have any issues. So you can see here, this is what I'm saying. Adequate resuscitation because stasis is preserved. Okay, but the center part will always be dead. Okay, and then if inadequate resuscitation is done, then the zone increases in size. Okay, we have systemic changes. So this is the second one, which only occur when the total body surface area that is affected by the burn is more than 30%. So you don't get it if it's less than 30%. And when we're talking about cardiovascular, you tend to have increased vascular permeability. Okay, peripheral capillary permeability is increased, which usually leads to losses of proteins and fluids and all that stuff. Okay, and then this now causes peripheral and these vessels that are supplying the intestines to vasoconstrict. Okay. At the same time, the contractility of the heart is really affected, and this is even worse for electrical burns. Okay, where you have now myocardial contractility is reduced. This is mainly by the tumor necrosis factor. Okay, so this is what I was telling you about chemical changes. So the changes because of also there's fluid loss. Okay, so for every total body surface area that is lost, there's a certain amount of fluid that can actually be lost, and we'll talk about this later on. But because one, you have increased permeability, okay, vasoconstriction peripherally and in the visceral blood vessels, reduced contractility, you're going to get systemic hypotension. If you guys remember that equation, yeah? So uh, heart rate times cardiac output is equals to your pressure. So cardiac contractility is controls the, is it the heart rate or the cardiac output? Can't remember. But the result effect is this is systemic hypotension, and systemic hypotension leads to end organ hypoxia, and then all those other things happen. Okay, so this is that. This side explained. Okay. Uh, Then we have, I want to talk about respiratory first. We have the immune system. So the immune system tends to be downregulated. It's not a specific mechanism, but you have downregulation of cell-mediated and humoral pathways. At the same time, you also have that breakage of the barrier. Okay, because you have reduced immunity, now you have respiratory issues. Okay, so respiratory issues can be caused by two things. The immunity is down, or it can be caused by those release of those factors that I was talking about, which now cause bronchoconstriction and then leads to acute respiratory distress syndrome, which is very common right now with COVID. While at the same time, because you have reduced immunity, you tend to get fungal infections in the lungs. You tend to get what do you call it? Just random weird infections that you would not get. We talked about the metabolic rate. It tends to be increased. It can even be increased up to 3 times. Um, and this leads to issues. So you find that some of these patients, when they get burnt, they lose a lot of their muscle mass. So parenteral nutrition might be very important in this particular patients. The next one is electrical burns. So in electrical burns, you have two main mechanisms. So you have electroporation and thermal injury. Okay. Um, hmm. Evelyn Ndumo.
Yes.
What is the what does electroporation mean?
Um, I don't know. I don't.
Okay, electroporation basically means that the cell membrane is broken down, okay, by the electricity. Okay, so it breaks down the cell membrane, creates pores. So you have release of ions and all those things, things that you don't really want. Thermal energy basically results from the electrical energy being transported on your skin, which has resistance. Okay, on your skin and your other underlying soft tissues. So the skin has the highest resistance compared to the other underlying tissues. So that's why it's mostly affected. And then that energy, electrical energy, is converted now to thermal energy. So I sent these notes I sent these slides to Vincent before. I hope you had a look at them. In the notes part, I wrote the importance of different types of currents, the importance of voltage, and the importance of body what do you call it, resistance and pathway of the current. Okay, so I'll quickly just mention those ones. So you benefit more if you get shocked by a direct current compared to an alternating current. Okay. Um, if you have a low frequency current, you tend to have contractions of your muscles, and then you hold on to the thing that is causing the shock. So that means if you have a low voltage, if you have not a low voltage, a low frequency current, you tend to get more burns, okay, and a prolonged exposure compared to high frequency ones. So low frequency currents tend to cause more damage. So I just wanted you to be aware of that. So voltage, the higher the voltage, the more the damage, of course. So it will cause more deeper burns. Body resistance, I've already mentioned that the skin, based on the skin thickness and dryness, so dry skin, of course, will have more resistance compared to wetter skin. Um, and then the underlying tissues tend to have lesser resistance, so they're less susceptible to the burns. Okay. The pathway of the current determines whether you have other comorbid things happening. So if it goes from the source point being the point of entry and the ground point being the point of exit, if the current is going from your arm to your arm, there's a high chance it will pass through the heart. So you might get arrhythmias. If it goes from if it touches your head, there's a high chance then you might affect your CNS and have issues in the CNS. If it goes through your feet and passes through the other side of the feet, there's reduced damage, but it will most likely damage what? Your urethra, all those things. So that's basically what I'm talking about. Yeah? So if you see that in the notes, that's what I'm trying to mention. The next point is pathophysiology of chemical burns. So this is depending on the concentration and how long you've been exposed to. So sodium hypochlorite is usually the bleach that we use in the house. So based on the concentration, you can actually get a lot of protein coagulation when it is in contact with the skin. It also causes esophageal constriction and perforation of the stomach if you ingest it. So that's why some people tend to use it for suicide. I'm not encouraging that, but yeah. The next one is phenol, which, as you can see, this lady has applied on her face. Usually comes with those, what do you call it? This thing is the skincare routine kind of things, the skin peels. So when you apply it on your skin, what it does is it causes demyelination of nerves and disruption of nerve endings. Also, because they're very lipid soluble, they can easily be absorbed by the skin. So if they absorb by the skin into the dermis, they can even cause arrhythmias and death, and even cerebral edema, hemolysis. So the main pathophysiology of the phenol is causing what do you call this? It's causing that demyelination of nerves. Okay, but it also causes peeling of the skin, and that's why you have all this that's happening. Okay, but if you have too much, then you get a burn. White phosphorus causes oxidation of tissues, and when it oxidizes, it generates heat, and then you get a thermal burn. Sulfuric acid, usually found in lead acid batteries. I don't know whether we still have lead batteries. I've not seen one yet, but we have fertilizers which have sulfuric acid, and in such cases, it causes coagulation of skin, just like thermal burns. Okay, and then you have sulfur mustard. Sulfur mustard was used in the World War, basically. It just causes necrosis of skin and damage to DNA. Okay, so you usually tend to form blisters and vesicles. Okay, so we can answer this question quickly.
Bukan bahasa historia kelas kan bisa. Ada minimum.
Can see majority of you have gotten it. So TBCA means total body surface area. Sometimes people say it's total burnt surface area. It's good that you guys are not saying that. Um, so back to our presentation. So we'll briefly talk about, if you don't remember anything from this tutorial, basically, this slide is the most important, yeah? How to manage burns. From cooling to prevention of hypothermia, to airway protection, fluids, GIT care, pain management, wound care, and then tetanus prophylaxis. This, I think, are the points that they want you to say in an oral, even when you're seeing your patients in real life. Okay. So in cooling, basically, there's some points that I will talk about here because I won't mention in the other slides. So the first one is like cooling. So cooling usually run mostly cold running water from the tap most of the time for at least 20 minutes. Usually it's usually room temperature, but it can, if possible, I haven't met one a tap that just opens cold water. You can use the dispenser water, which tends to be colder. For around 20 minutes. It has some pain relieving effect, but you can keep up to 3 hours. You can keep the whatever, let's say it's the hand, you can put it up to 3 hours. But the problem is you can actually cause maceration of the wound, which we talked about last week. Okay, so we don't want that. Again, someone can become now dependent on that water, which means you can't do anything. I had an experience like this in one of my calls when I was in internship. I got burnt on my hand, and I was on call at the same time. So I was walking around with an ice pack on my finger, but that now made me very dependent on having that thing that was cooling me. So the ideal time is try to put it for at least 20 minutes, maximum 1 hour, so that you don't get, or that patient doesn't get dependent on having that cool thing on them, because now it makes them unproductive. So now, other than using that to relieve pain, now we talk about pain management. And last week we talked about there's 3 steps that you have to go through for pain management. I don't know who I asked last time and they didn't know, but I'm hoping by now you guys have gotten that pain management stepwise. Okay. So usually, most of the time, oral medications will not work, especially if it's a superficial burn or a superficial partial thickness burn, because they're very painful. So like for me, I had to get an injection just to relieve the pain. But the others, you might get away with giving oral medication. Okay. So to prevent hypothermia, you have to remove those wet packs. Okay, as I was saying, it may cause maceration. You might have to cover the patient because they've lost a lot of skin or whatever has happened. You may need to cover them in those reflective wraps. This I don't know whether you guys have ever seen them. I wish I put a picture. But if you ever go somewhere at night, you might find that those guys for St. John's, they put you in a plastic bag, especially if people black out, like at a party or at a function. So they tend to put you in that kind of situation so that you don't feel cold when you blacked out from all that alcohol. But again, you can also cover them with blankets and all those things. Okay. So for airway protection, fluids, GIT, we'll talk about in the subsequent slides. So does anyone have a question as pertaining to cooling, prevention of hypothermia, and pain management before I continue? Tetanus you give. You assume someone has not gotten tetanus. Does anyone have a question in relation to that? I doctor's a question. Was the cooling issue causing hypothermia itself? Not really. The cooling we tend to do it again for wounds where the total body surface area, like for children, is like less than 5%, and for adults it's less than 10%. Okay, so in such situations, you are avoiding hypothermia by doing too much cooling? So that's a very good question, actually. So less than 10% for adults, less than 5% for children to avoid hypothermia. Sawa. So for acute management, which will encompass those other things that we didn't talk about, we have a primary and a secondary survey. So primary survey is to ensure the major things out, things that might kill a patient immediately, and then the secondary survey is now to give definitive management. So the primary survey involves A, B, C, D, and F. So you have airway with you have to check your airway, put a cervical collar, breathing, make sure the patient has oxygen, circulation. We talk about fluids. Check whether this patient has some neurological disability, especially if it's electrical burns, exposure. This is mostly for chemical burns where you might have to remove all those things, and then fluid resuscitation. So what we want to see in the history when you're talking about a burns patient is the mechanism of injury. Okay, so the nature of injury. So is this a scald? Is this a flame? Is it a flash? Is this electrical? Is it chemical? Is it radiation? Okay, when did this happen? The time of injury. What treatment has been given? Okay, what are the risk factors associated with any other injury? So when they got electrocuted, did they fall from the pole? Okay, so that's what we want to know. Was there an explosion that threw the guy to the wall? So that means that this guy probably has some head injury. Suspicion of inhalational injury. This one we'll talk about later, but still, can you see any of those signs that would tell you that this there could be inhalational injury? Was this an open area? Was this a closed area? How long was the patient exposed to smoke? And then now the past medical history, which is usually say sample. Does anyone know what sample stands for? It's a mnemonic. Okay, you can go check. For past medical history, you use the sample. It's a nice way of remembering all major past medical histories. Okay. So this is what now you're thinking that this patient has a burn, yeah, has an inhalational injury. First of all, is there anyone brave enough for Valentine's whatever? Valentine's. Can someone tell me the pathophysiology of inhalational injury? How does it cause damage? I didn't mention it when I was talking about different types of injuries. Is there anyone brave enough?
I think the exposure to.
Sorry, I think you have multiple things. Who's speaking first of all? Sorry.
This is Maria.
Maria.
Yes.
Okay. Yes. Tell me.
I think exposure to, for example, if it was like fire, so exposure to the hot smoke will somehow start like the inflammation cascade, and then you end up with edema in the mucous membranes.
Okay, good. So that's great. So you've talked about one pathway. There are 5 of them. So you've talked about the increased airway blood flow, which causes airway edema and narrowing of the airway, which basically prevents alveolar ventilation and impairs pulmonary gas exchange. Okay, so that's one way. What about the other 4? Do you know any other 4?
I'd have to think. That's the one I know, the one I've said.
Okay, so anyone else want to add on other than airway edema? Anything else that would be happening when you inhale smoke?
I think there'd be damage to cilia.
So if there's damage to cilia, what happens?
Any secretions that are produced even now during the inflammation are not cleared. So there'd be
Which secretion specifically?
first of all the plasma that comes out from the cells because of the inflammation.
Okay. I think in the right direction. You were talking about secretions. What secretions are in the airway? What secretions are this that we keep giving people cough syrups and all these things to try and promote?
Mucus.
Yes. So when you get smoke inhalation, we stimulate the release of secretion. There's increased secretion of mucus. So you tend to form casts. Okay. So you might see this even, I think, since you guys are using up to date, you'll see casts. And those casts tend to form airway obstruction, which then causes all those things I was saying: airway, the airway is narrowed, reduced alveolar ventilation, impaired pulmonary gas exchange. Okay, so those are two. Any other three?
Try the
But
third one.
there's something you mentioned about the cilia.
Yes.
So other than mucus, what else can the cilia do?
They can, if they suit it, they can also attempt to clear it.
Mm-hmm. But what happens to what happens to the layer that usually has cilia? What does it do?
It slows off.
Yes. So the airway epithelium exfoliates. So it exfoliates like skin when you have this smoke, and that also contributes to the formation of casts. Okay. I think you're doing well. So we've done 3 out of 5. Anything else? One more.
What about,
Sorry.
hello, it's Maria again.
Uh-huh.
What about like because of the irritation you get like bronchospasm, kind of like asthma?
Perfect. So that's the fourth one. So bronchospasm. So the last one is not related to the lungs per se. So it's an independent factor. So this one might be a bit difficult. Anyone can think what else could be happening with smoke? Okay. So smoke tends to stimulate the coagulation pathway. So you tend to now form microvascular clots in the pulmonary system, which tends to impair exchange of gases. It's remember like when we talked about venous ulcers and we talked about the fibrina cuff. So the same thing is happening. When the smoke comes, it activates the coagulation and then it forms a cuff around those vessels. And then that causes impaired pulmonary gas exchange. So that was good. So we have coagulopathy, bronchospasm, we have mucus secretion, we have airway epithelium exfoliation, and then you have increased airway blood flow, which causes the airway edema. So I'll send, I'll try to look for an image and send to Vincent. He shares with you this concept. So good. So when we're talking about how do you know that someone has an inhalational injury? So you see this guy of ours has, what does he have? This guy of ours has first of all, they tend to be flames. So flame burns which just explode on their face. So again, the face is affected. Face and neck will be there. So it doesn't have to be specifically deep and deep burns or full thickness burns, but they tend to mostly be face burns. Okay, flame burns. They're usually in an enclosed space, but this can also happen in an outdoor setting, unfortunately. Especially like I don't know whether you guys saw this these guys in Lemuru who got burnt just the other day. So those guys happen to have those burns. And then you have syringed nasal airways. Syringed nasal hairs. Eyebrows also will become syringed, so they tend to be coiled. You have this carbonaceous sputum. You can't see it, but you can see carbon. You can see all this soot here. And the voice tends to become hoarse, and you have stridor and wheezing. Okay. So the next one is, how do we investigate inhalational injuries? Other than just intubation is actually part of management. So if you suspect someone has inhalational injuries, you might have to intubate, and we'll talk about when to intubate. So the first thing is, if you can't, just do a chest X-ray, right? If that is not available, if that is available and is more, you can do a bronchoscopy, and you can do an arterial blood gas to see how to calculate the carbon monoxide exposure. All right. So if someone has been poisoned by carbon monoxide, you tend to give 100% oxygen. So in these images, I'll ask Nikita. See Nikita. Nikita Zuri. Are you with us? They can't speak, or but can't unmute. What about Kenan? I'm seeing this Kenan here as well. Kenan. Why not talking? Pauline Jockey. Class rep, Vincent. Save your class. What is in this chest X-ray? What can you see? These bad guys are shy. They can't hear me. Anyone want to tell us what they can see on this chest X-ray?
I can attempt. This looks like a PA radiograph of, well, it's not written, the biodata, but it is of adequate, in the inspiration it's adequate, there's no rotation, and the penetration is also good.
You can see visually behind the. Okay, I can't see that well, but okay.
Okay, yeah, true. In the lung fields, I think you can see some opacifications, just diffusely across the entire lung fields, both on the left and the right, especially in the middle lung zones.
That's opacification.
And someone else can add.
Basically, we call that pulmonary infiltrates, and it's very non-specific. So it won't really tell you what is happening, and that's why I was saying if you have an X-ray, you can do it. It will not tell you, but what you're looking for is that basically that whitening. Yeah. So a bronchoscopy is much better because you can see, like for example, this is the carina, this is the right middle lobe, the right lower lobe. Basically, that's what they're labeling. And you can see in the bronchus, yeah? In the bronchus, you can see all these soot. So that is a high indication of what do you call this? Of inhalational injury. So when should you intubate? So when the neck when the neck area is affected, or even when you're putting the bronchoscope, you can see that it's very swollen. You need to intubate. If there's change of voice, it's hoarse or harsh, definitely need to intubate. It goes on the patient's face, just intubate. Okay. And what is the thickness of this band? Okay, so what is the total body area of the band as affected, and how deep does it go? So when we're talking about total body surface area, you can use the rule of nines by Wallis, but there's the Ladbrauda. I don't know whether anyone is aware of it. It's a bit more accurate compared to this rule of nine, although you tend to find that all these are just estimations. And fortunately or unfortunately, most of the time, we all tend to underestimate the the total body surface area that is affected. Again, this is because most burns do not decide that I'm going to just burn specifically this part of the lower abdomen. Okay, sometimes you find it as a burnt this part and then part of the skin over the ribs. So what is that? Is that 13.5? Is that 10? Is that 11.5? So it's just an estimate, yeah. So, but the broad, I think, I don't know whether your lecturers that's what they've told you, but that's the one that most people are tending to now shift towards. But then the rule of nice is easier to remember. Does anyone know what the palm rule is? Dorcas Atieno, what is the palm rule?
Wow.
Mm-hmm.
I can only guess, but I have not heard about it. That
Yeah.
maybe they're using the surface area of the palm and trying to fit that onto the body surface to find out how many, yeah, palm surface areas the
What is
burnt
the
area.
what is the surface area of the palm?
Um,
Just the palm itself, not the palm or surface of the hand.
about 2%. I guess so.
And a bit too bad. It's usually around 0.5 for the palm part, and then the palmar surface, the whole of it, is usually around 1%. But if you use the broader, let's say 1.25. But the palm rule basically says that the palmar surface of the hand, not the palm itself, the palmar surface accounts for around 1% of the total body surface area. Okay. Is it
Thank
my
you.
computer? Okay. So basically, if you're not so sure about your nines, just take the patient's hand. It's cuts across. It's not for adult pediatrics, because for pediatrics we talk about you have to use another system. Okay, so the 1% of the palm, you can actually use it to try and estimate how much is it. So what do we use for children? Swale Mohammed.
I don't know.
Okay. So for children, you'll find that when you go to Kenyatta and even in internship center, they tend to use now the lab browder charts. You'll find them in most outpatient, so that they can tell you for what age group what the total body surface area is. Okay. So go check out that chart that I'm talking about. So in the upper right corner, this is what do you call this? An epidermal burn, or what they call as sunburn, or in this case a superficial burn. It's just affecting the epidermis. All right. So you'll have skin peeling. Within 7 days, you'll be fine. You'll have healed. You'll have forgotten about it. But it's very painful, very sensitive, turns red. This is someone who had gone to the beach over the weekend and just got a sunburn. So this is the second one. This is my friend. He was cooking chips and the oil spilled on his hand, and it ended up getting these blisters. So you tend to find blisters with second, not I won't call them second degree, with partial thickness bands, be it superficial or deep, you tend to have this blistering happening. Okay, very painful. Blanches to pressure when it's superficial, or when it's deep, it doesn't. It tends not to blanch. Um, Someone else. Michelle, why do you think it tends to blanch in superficial and then in deep it doesn't blanch?
I'm not sure.
Okay. We'll see why when we're talking about now. Okay, basically the dermis is where you find blood vessels. Okay, so if you go all the way all through those layers, if you go to all the way to the deep partial, okay, if you start from the epidermis, which is the superficial bands, it tends to only affect the epidermis. The superficial partial thickness affects the dermis, but only the papillary area, and then the deep partial thickness affects up to the reticular area. Okay, but not the entire skin. And then full thickness affects both the epidermis and the dermis completely. And then you have deep band injuries, which tend to go below, and that's what they used to call the fourth degree burns kitambo. So the reason we're not having blanching when there's pressure is because your vessels are damaged, so you won't have that kind of return of blood after you press. Okay. Again, they tend to be very painful, the partial thickness bands, but the deep partial thickness are usually moderately painful, but they tend to, the sensation that you get from those types of bands is mostly pressure, not pain. Okay, full thickness is purely pressure, and then deeper is just pressure. Okay, so it's painful, very painful, and then kidogo painful with pressure, and then pressure. Right, I hope you've understood that concept. So that's what's happening here. And then this one, which is a bit leathery, multicolored, tends to be the full thickness. So they tend to have a waxy white leathery appearance, sometimes charred and black, dry, inelastic, and there's no blanching. And it's because of those vessels that you've damaged completely. This one does not show it clearly, but sometimes you have this cheesy white appearance. And I'm sure you'll see it when you start seeing these patients being dressed in your facilities. Okay. So this one's we say that the skin burns, the sunburns tend to what do you call this, heal within a week. The partial thickness, depending on how thick it goes, the superficial will heal within 3 weeks. Like I wish I have a photo, but I don't know whether I should send it. But anyway, I have a photo of his hand, and it's not healed completely. It's not been 3 weeks yet. You'll see that you'll have a lot of granulation tissue. So all these things I'll send to Vincent after the class. All right. And then for deep partial thickness, usually after 3 weeks, it will heal, but you might have to do some surgical intervention. That is for the deep partial thickness. For the full thickness, it will rarely heal on its own. So you have to do something, either put a graft, just try do something surgically to try and help with the healing. And if it's a deeper injury, which we're calling the fourth degree, which is going to the fascia and the muscles, for sure it will not heal, because you've gotten rid of the basal epithelium, which tends to populate the cells. So you have to do some surgical intervention in that case. Okay, I hope this is clear. So again, most of the time we tend not to use this first degree, second degree, but you can use it. It helps, but it's good to use the superficial partial thickness, the partial and full thickness, because it helps you in management of patients. Okay. There's a very high chance you don't need to admit any first degree or superficial burn, but even the superficial you might, but the deep and the full thickness you have to admit. Okay, and we'll talk about when to refer and when not to refer. Okay. So what are critical burns? Critical burns are burns that if you do not act on immediately, there's a high chance that your patient will die. So if you have 10% third degree burns, which we said was full thickness burns, more than 10%, you have to try and sort out the patient. Even if you're just putting a line and giving fluids, you have to. If it's a partial thickness or a deep partial thickness burn, if it's 25% and over, there's a higher chance of mortality. And then third degree burns, full thickness burns to the face, the hands, and the feet, there's a high chance of death. So when should you refer? I think you can go and interact with these 12 points. But basically, the point that we're trying to make here is full thickness burns, all special burns, which is electrical, chemical, inhalation, you have to refer to a burn center. But then when I say refer, I mean these are burns that they have to be treated in a burn center. If the criteria does not meet this one, you can easily manage in a level 5 hospital or level 4, wherever you decide to do your internship. They always have a burns unit. So you have to decide based on this. So you've said electrical burns, chemical burns, inhalational burns. Fits your face, genitalia, perineum, along with. Okay, so that's the wrist joints, the elbow joints, the shoulder joints, the ankle, the knee, and the hip. Those ones you definitely have to refer. What else am I not saying? If someone has a comorbidity, if someone has diabetic, hypertensive, again we say that in burn patients they tend to have insulin resistance. So these are things that you have to take into account. So if someone has a comorbidity, any other disease that is being treated as well, you have to refer that patient. You'd rather have them in a setup where they have specialists around. If they have any other type of injury, which is very common, especially with electrical burns, fractures, head injuries, please refer. Circumferential burns, these are burns that are going around a body part. So if they are going around, let's say for example, the forearm, not just one side of the forearm, but it's going from the volar surface and going to the other side, the extensor surface. All right. So if it's going around, or if it's going around the stomach, that one you have to refer. Okay. Let me see. Damaris Gasheri. Why is it that we have to refer circumferential burns?
There's a risk of getting compartment syndrome.
Okay. What's compartment syndrome? Hapo ndo imeisha. But it's okay. That's the reason. We want to take these patients to set up where if they have compartment syndrome, most of the time, Damaris, it's caused by what? What causes the compartment syndrome? Damaris, what causes? Do you expect compartment syndrome with partial thickness or full thickness burns, and why?
I'm not sure. Not sure.
Okay. You tend to find them with full thickness burns because of eschar formation. So eschars tend to constrict and prevent movement around those particular body parts. So because of that, you tend to refer. So you have different compartment syndromes. There are those ones for the upper limbs, those ones for the lower limb. There's also abdominal hypertension, or intra-abdominal hypertension, or abdominal compartment syndrome. Go check it out. So the pressure usually goes above 12. You tend to see these things in ICU. I don't know whether you guys are rotating in ICU, but you tend to see them in ICU with circumferential burns. So the other one is ban to child without any qualified occupant for care. So this is in a situation whereby you're in a setup and you're like, we can't really do anything. Let's say you don't have gauzes to keep dressing the child. You don't have the patient is probably abandoned and all the things. You have to refer to a better facility. Again, you usually refer patients when there is an element of social, emotional, and rehabilitative intervention that is needed. Okay. So this the example I would give is people with chronic illnesses, whereby let's say the cerebral palsy, people with some level of mental retardation. Those are patients you might not want to just treat in your hospital. Um, Again, they may not be as compliant to the things that you're telling them, but at the same time, it would be better for them to be in an environment where they have as many specialists as possible. Okay. Um, so these are the others that I didn't mention because you can always read on your own. So if you have more than 20% body surface area burns in adults and not the elderly, then you need to refer. And then if it's more than 10% in elderly and pediatrics, then you need to refer. So that slide was very high yield. If you need to, if you can't understand it, then you try and cram it before the exam, so that if they ask you an MCQ on the following, not a result to refer, you can easily pick out which one it is. So fluid resuscitation, which is like the cornerstone of burn management before you even refer. We don't do fluid resuscitation if the total body surface area affected is less than 20% for adults. Again, if the total body surface area is less than 10 to 15, you don't really tend to use it for children. Again, we tend to use only total body surface area when we're talking about partial thickness bands and above. We don't talk about when we're talking about superficial bands. Most of the time, superficial bands, you don't need to give fluid resuscitation. Just take painkillers, drink water, you'll be fine. Okay. Hi, someone wants to know what the Parkland formula is? We choose Hassan Abdi Ahmed. Crystal Kaigai. Guys, you can finish. The library can't stop. Oh. No, sorry. So, sorry. So yes, someone has answered in the name. So it's 4 ml per kg. So 4 ml multiplied. So you've divided in that thing that you've written. So it's 4 ml multiplied per kg per total body surface area. All right. And this is usually given, half is usually given within 8 hours, and the other half is given within the other 16 hours. So do you give maintenance? Sylvester Mwema, do you give maintenance or no? Linda, do you usually give maintenance or no? Sorry?
I'm guessing you have to.
Yes, to who specifically do we give? I don't know who's answered. Who do we give maintenance to? We usually give maintenance fluids for children, for pediatrics. For adults, you may not need to give maintenance. All right. There's a way you calculate maintenance fluids for children, and I'm sure you guys know how to do it. You've already passed pediatrics. So how do you know that you're giving enough fluids? Washira Minor, how do you know you're giving enough fluids? Victor Malway, how do you know you're giving enough fluids?
I check for the vitals. If the vitals are stabilizing,
Mm-hmm.
I'm doing well. If there are no signs of shock, then if there are no signs of dehydration as well,
In terms, sorry to
I
interrupt.
look at the mucous membrane.
Sorry,
Skin tag.
which one specifically are you looking at in terms of vitals? What specifically is it? Victor, which one?
The blood pressure and the pulse rate.
Mm-hmm. Other than that, is there anything else you could do?
The blood pressure and the pulse rate.
Okay, other than the blood pressure and the pulse, usually the skin tagger will not change so much acutely. But what else can you do? That's a good suggestion. I'm seeing guys have already written it in the answer. So it's the cardiac output. Sorry, the urine output. So you put a Foley's catheter. So it's very, very important, you guys. When you get burns, some of them might be conscious, but put the catheter. Especially electrical burns, some of them are very conscious. They're in a lot of pain and they think you're put the catheter so that you know you're giving enough fluid, because there's a high chance of underestimating, especially with inhalational burns. There's a high chance. So just give 0.5 to 1 ml per kg per hour. So that's the output that you want, the usual. So. And then check the urine to see if there's any issues. So is there blood in the urine? Because that would suggest that there's some acute kidney injury, especially with the electrical burns. So intravenous or intraarterial access, it depends. So if you're able to put a line, okay, if you're able to put a line, one of these two. So the blue one, I'm sure you guys have seen this, you'll be in the ward. What is the gauge for the blue one? Natasha Odhiambo? What is the gauge for the blue one and also gauge for the purple one? For the pink one. Anita Wamboi?
Yes.
What is the gauge for the blue one versus the gauge for the pink one? I'm sure you've seen it in casualty, in the wards, and they're asking you to feel that fix a line.
I don't really remember.
What are these considered as? These two lines.
I know they're smaller than the gray and green.
Mm-hmm. You see, someone has tried to answer. The blue is 22. Okay. And the pink is what? 16 or 18 or? Okay. Is the pink 20? Okay, so what I was trying to impress upon you guys is that the blue one, which you guys have rightly said is 22, is a large bore cannula for pediatrics. So this is what you might put for pediatrics. All right. And when I'm saying pediatrics, is a huge range. Again, you still have to be very specific. You can put the yellow one or the purple one, but still if you can put this one, the better. And then for this one, it's for the adults. So you should start with this one. Most of the time, you find that people put this, but this is what at least you should put. This is at least the one you should put. So it's large bow cannulas. All right. So there's the green one, which is I think 18 gauge. I think so. And then you have a gray one. I wish I put the gray one here. The gray one is very important, especially for not just burns, especially for fluid resuscitation. When you guys go for internship, you need to get those gray ones in your pocket. You need them for PPH management. Very, very good things to have. So which fluid should you give? Someone can quickly write in the description. You don't have to ask someone specifically. Someone said colloids, crystalloids. Which crystalloids specifically? Yes. So, and then what happens after 24 hours? So you've given this person resuscitation fluids, the urine output is okay. What do you do in terms of fluids afterwards? Do you continue giving them IV? Do you give them orally? What do you do? So it depends. Again, depends on how the patient is doing. But most of the time, they will right now be in a situation where they can take orally and they don't need IV drugs. But fluids is a must. So you need to know how much output they're actually offering. So the last part of our talk today is wound management. So you have topical ointments, you have dressing, synthetic versus biological. Let me put the picture of a fish. Okay, sorry. Hysterectomy, and then sorry, someone's calling me. And then surgical considerations. Topical ointments, antibiotics. So you usually use silver sulfur diazine, which is the most commonly used ointment, but it has a half-life of 10 hours, and this is they usually put it with the semi-occlusive dressing. So it really does not, it has been shown not to have much benefit. It's just that unfortunately or fortunately, you'll find that this is what you will be doing in the peripheries. But if you have a silver nitrate impregnated dressing, that would be better because that prevents infection, because that's the main reason you're putting the topical ointments. You have mafenide. I think that's the way you say it. MAFENIDE. Usually we put that for full thickness burns, and it tends to reduce infections, and also it reduces the unfortunate thing is that it causes metabolic acidosis. So all these things are give and take, right? But the best, if you have to put, is silver nitrate. Okay, and then even better than that, you put honey. Honey has been shown to be the best in terms of burns wound ointments, basically. And there's someone even, I think one of the plastic surgeons, the resident, is doing a study on that, just to bring it back home so that you can start putting honey on people's wounds. Wound dressing synthetics via biological. I was to put here a picture of the tilapia skin. It has been shown they put it to try and help with the dressing, but most of the time we tend to use synthetic gauzes. So now what will happen with burns is that most of the time we tend to use semi-occlusive dressings. Does anyone know what semi-occlusive dressing is? Mayaba, Humphrey, what is semi-occlusive dressing? Gideon Nyakundi. Not really. Someone is on the right track. What do you mean by allows the wound to breathe? Okay, that's true. So go check out what is occlusive dressing, semi-occlusive, and an occlusive dressing. Those are very important. I think last time I said I just gave you the link for up to date to go read, but you need to understand those ones. So for burns, we tend to use semi-occlusive. So it allows air in, but at the same time protects it from fluids. Escharotomy, that is those eschars that tend to form with full thickness burns. We cut to reduce the constriction it has. So if you have it on the chest, it prevents what do you call this expansion of the chest. Another thing that I forgot to mention actually, on the chest, especially for the ladies, the reason sometimes it's hard to estimate the amount is because of the breast. So the breasts tend to increase the superficial, the total body surface area that is affected by the burn. And then you have surgical considerations. For this particular case, you don't do primary closure. You don't. Most of the time, you tend to do healing with secondary intention, or you tend to do grafts and flaps to try and reconstruct that area. And different parts of the body can be reconstructed in many ways. Okay. I hope that's clear. Last time we talked about the reconstruction ladder, so I hope that is okay. So this is, I think I've left you guys with so many things that you need to go check out. But this is another I think you guys are doing forensic pathology. Go and check out, like, okay, fine, someone has gotten burnt, but this is not really an accidental case. How do you know it's abuse? So those are things, okay, you might not be asked in surgery, but it's good to know for pathology, for the forensic pathologist side. But again, you tend to see this also in surgery. So it's good to know when is this an accidental and an accidental. And I've put an image just to try and help you out before you start. So you might find specific areas. You have cigarette burns, all those things. Again, I said, if you don't remember anything, make sure you've understood these slides. Okay. There's cooling, there's prevention of hypothermia, airway protection. Remember we talked about intubation. Circulatory care, we talked about fluids, Ringer's lactate, Parkland's formula. There are many other formulas, but Parkland's is one you use mostly. Maintenance for children. Remember, if you have intravenous access, try and use intravenous, but sometimes they may be so burnt that you may not be able to get intravenous. So for children, you do intraosseous. You tend to do intraarterial. I forgot to talk about that, but we tend to use intraarterial, especially in ICU, because it's just easier to have that fixed, and you can have it for a prolonged period of time. Pain management, we talked about WHO last time. Wound management, we have talked about it, and tetanus prophylaxis. So these are the last questions we answer, and then you guys can be on your way. Mm-hmm. Mm-hmm. 3 more guys, and then I give you the answer. We can go. One more person, and then I close. Go to the next question. Anyway, so 50% of you guys got it right, yeah? So it's 30%, that's when you tend to get those systemic changes. I mentioned it in the presentation. So Mwangi, 28-year-old male, comes to A&E with a blistering wound on the dorsum of his hand from burning cooking oil. As the MOI, as the intern, would you refer, and why? Why should you? That's the question. It's blistering. Yes, because burns to a special area. Not, it's a partial thickness. Yes, but the hand is a special joint. Okay, I'm conflicted. So I think it would be good to refer this patient, and I think you guys have said the main points. It's around the wrist, so there's a chance of getting contractures and getting sorry, you won't get contractures per se, you will tend to have hypertrophic scars, but because it's around the hand, it would not hurt to refer this patient, and it's a special area. Okay. But then again, your judgment is very important in such patients. This was a very tricky question. So at the end of the day, there's no right answer per se. There's no MCQ which will ask you whether yes or no. This is more of a clinical judgment. I wanted you to be able to put yourself in that position. If you see that this wound is going around the joint, then you definitely need to refer that patient. Even if they'll go there and be discharged as an outpatient, it's better to be sure. Again, if it just affects, like that friend of mine, which just affected the dorsum of the hand, but not the entire hand, just the one finger, not necessarily. I think that you can get away with deblistering and dressing it. Again, when you're talking about deblistering, we tend to do deblistering for people we tend to think that are going to be in a situation where the blister will pop, especially if they use their hands a lot for mechanical stuff and all those things. So So you want to deblister because they pop it at some point and get infection there. So you tell deblister and cover it, and even children. But for others, especially people who work from home, even you as a student, and let's say you're in home health and you don't really need to use your hands a lot, you can survive for those 3 weeks without necessarily deblistering. After the 13th, the third week, the blisters will have already resolved and you won't even have a scar. Okay, that's something I didn't mention before. So that's basically it, guys. Any questions before I disappear? Let me check this. It's in the chat. Please clarify the reason behind nutrition demand increase in pathophysiology of burns. This is in relation to repair. Again, your burns tend to increase the metabolic rate by 3 times, so your nutritional demand increases. That's why. So one thing that I did not talk about specifically were the complications of burns. Something like Carling's ulcers, eschars, all those are things you can check out on your own and find out. If there are no other questions, I think we can call it a day. I think next week we are doing, what are we doing next week? Vincent.
Yes, Doc.
What are we doing next week? Remember?
Next week, I'll confirm, then let you know.
Oh, we're doing soft tissue diseases. I can send that to you. What time? I think we should agree on a time so that we are always consistent. The other group we used to do 5:30 to 6:30 so that they have a 30-minute break from the class before. So I think we can always be doing that. I know it's unfortunate about the Muslim brothers, but I think that's the best time because I think you guys have classes every day.
I think we'll agree on a time, but the thing, it's better if we have earlier, like 5:10, 5:15 there to 6:15.
My fear is that we tend to, if the class like if your other class prolongs, then it becomes an issue because now I have to wait for you guys to finish. So I think that would be a good time. We used to do 5:30 and everyone was okay with that. If there are any other questions, you guys can find me where I told you guys can find me. But yeah, I'll send you those pictures and then you can send to the guys and then the questionnaire and the slides for next week.
Okay,
So
thank you.
thanks. Enjoy your Valentine's and your dates, whatever it is that you guys are doing tonight.
Okay.